Welcome to the Degrees of Health podcast, a podcast dedicated to your physical, social, and emotional health. Conversations that add life to your years and years to your life. Join us each week as we speak with world experts operating in a wide range of disciplines, practices, and various degrees of health. Well, look, Dr. Bryan, thanks so much for coming on. Really appreciate your time in advance.
Of course. No, thanks for having me.
Well, we were lucky enough to have a little early read of your book, which I really enjoyed. I have loads of questions. But I think a good place to start the episode is very simply, what is nitric oxide?
Yeah. Well, again, thanks, Ben, for the opportunity to share a little bit about nitric oxide. But yeah, today we recognize it's one of the most important molecules produced in humans, in fact, all mammals. But it's a signaling molecule and it's a gas. So it's naturally produced primarily in the lining of the blood vessels. And when it's produced, it's gone in less than a second. But during that second it's around, it signals other parts of the body and other cells to do some important things. Its primary role is vasodilation. So when it's produced in the lining of the blood vessels, it dilates blood vessels. It improves oxygen delivery and oxygenation of tissue. It reduces vascular inflammation, inhibits oxidative stress, and suppresses the immune dysfunction that we see in chronic disease. So nitric oxide is the foundation for optimal health and wellness. And obviously, when we lose the ability to produce this molecule, then that's the earliest event in the onset and progression of chronic disease.
Okay, wonderful. And my understanding is you were quite influential in, well, I appreciate nitric oxide has only been around since the 1980s, right? I mean, as like a brief history of how we even discovered it, I'd love to hear your thoughts on it.
Sure. Well, there were really three independent lines of research that came together that really put the pieces of the puzzle together that told the story of nitric oxide. And it all started in 1977 when Fred Murad discovered that drugs like nitroglycerin, and in the 1970s, these drugs had been used for probably 150 years for the treatment of acute angina. And that's the chest pain and the ischemic pain in patients with advanced coronary artery disease. So these drugs were used for 100 years because they were effective, but no one knew how they were working. And in 1977, Dr. Murad and his group discovered that they work because they're metabolized into nitric oxide. Nitric oxide then dilates the coronary arteries, and that explained the symptomatic relief of acute angina or angina pectoris. So I think that was an important discovery in its own right, but really the main discovery came in 1980 when Bob Furchtgott, who was at State University of New York, made a discovery that our endothelial cells, and the endothelial cells are the cells that line all blood vessels throughout the entire body. And these endothelial cells produced a molecule that caused the blood vessels to relax. And in this 1980 paper, he called this endothelium-derived relaxing factor. So he didn't know what this molecule was, but he understood what it did. If you had a functional endothelium, when you activated the endothelial cells, it causes blood vessels to relax. But if there was damage to the endothelium and you get the same agonist, you get this paradoxical vasoconstriction. So this was a 1980 Nature paper. And then that really transformed the field of vascular biology because everybody in the field knew that this molecule was extremely important. They just had to identify what it was. And then 7 years later, Salvador Moncada and Lou Ignarro, about the same time, recognized that EDRF, that was described by Bob Furchtgott in 1980, was actually nitric oxide gas. So then that's really where everything came together because whether you're giving a nitric oxide drug or you're stimulating endogenous nitric oxide production, it leads to vasodilation, it signals within the cardiovascular system, and that was really the complete picture. And then, in 1998, a Nobel Prize was awarded for the discovery of nitric oxide, specifically as a signaling molecule in the cardiovascular system. And this signal transduction by a gas was a completely new paradigm in cell signaling. And that's what warranted a Nobel Prize.
Wow, I mean, I think I'm glad you went into the history a bit. I really enjoyed reading about that, and I think it brings it home for where most people have heard of nitric oxide is through nitrates. So if you do fun runs, if you're a exercise enthusiast, you've probably seen beetroot shots. You've probably seen rocket, which has more nitrates than beetroot. How does nitrates, as I guess people who don't study this, how does that relate to nitric oxide?
Well, I think there's been an evolution in the science. So when nitric oxide was first discovered, the only pathway that was known for the production of this molecule was an enzyme in the endothelial cells called nitric oxide synthase. And then that enzyme converts L-arginine into nitric oxide. But I guess probably the early 90s, it was starting to be realized that inorganic nitrate, and this actually goes back to the 1970s, when it was recognized that we take nitrate, which is found primarily in green leafy vegetables, and then our body intentionally takes it back up in the kidneys. So we're preserving this molecule. And moreover, we're actually concentrated in our salivary glands. And in the 1970s, the cancer biologists who discovered this pathway were a little bit confused because at the time people thought that nitrate formed nitrosamines and caused cancer. But yet the question was, why would the human body intentionally reabsorb this molecule and concentrate it in our salivary glands and recycle this molecule? And to fast forward 40 years, today we know that there are nitrate-reducing bacteria that live in the mouth, primarily in the crypts of the tongue. And then when we consume these vegetables, 90 minutes after we eat beets or spinach or arugula, green leafy vegetables, then our salivary glands start secreting nitrate. And then the bacteria on the crypts of the tongue perform this 2-electron reduction to inorganic nitrite. And then when we swallow our own saliva, we get a burst of nitric oxide gas in the lumen of the stomach. So there's three main steps in here. Number one, we have to get enough nitrate from our diet. Number two, we have to have the right oral microbiome. And number three, we must have sufficient stomach acid production.
That's so interesting. I wonder if, and I might be jumping a bit. I always go off script because I get excited. You mentioned a enzyme that gets released from your tongue. If you were to put loads of beetroot in a juice, for example, and just drink it, would you bypass that enzyme being released from your oral system?
No, so it's a bacterial enzyme. So humans don't have the enzyme. We don't express a nitrate reductase enzyme. So we're 100% dependent upon the presence and number of specific bacteria in the mouth to do this conversion for us. And you bring up a good point, because if you're using mouthwash or use fluoride or anything that acts as an antiseptic, then we're killing off the good bacteria in the mouth, and we completely kill off these good nitric oxide producing bacteria. And there's a consequence to that. Our blood pressure goes up. We lose the protective benefits of exercise. So we have to maintain and support a healthy microbiome, specifically the oral microbiome. Because if you don't, you can drink the beet juice till the cows come home. You can eat a plant-based diet. But if you don't have the right bacteria, you're never going to get a nitric oxide benefit from that. The nitrate's just going to go through. You're going to urinate it out. You're going to defecate it out, and you're going to sweat it out. It's unchanged because it's completely inert in humans. And this is where we're starting to see a lot of problems because, in the U.S., I know the statistics is 2 out of 3 Americans get up every morning and use mouthwash. I don't know what it's like in the U.K. or other countries, but I think it's probably a similar type of statistics, which means 2 out of 3 people are using mouthwash. And in the U.S., 2 out of 3 people have an unsafe elevation in blood pressure. And now we're beginning to explain that because it's a disruption of the oral microbiome.
Okay, so just taking nitrates, be it beetroot, dark green leafy vegetables, whatever it is, does not directly correlate with higher nitric oxide levels in the blood.
That's exactly right.
Okay, and things like mouthwash, and I know you've actually, that would be my next question. Things like mouthwash, and what else can disrupt that conversion of nitrates into nitric oxide?
Well, because we're 100% dependent upon the oral bacteria, anything that destroys the oral microbiome. So the most obvious are things like chlorhexidine, chemical-based mouthwash, alcohol-based mouthwash like Listerine, Scope. Anything that's listed as antiseptic is indiscriminate in killing the bacteria. It kills the bad guys, but it also kills the good guys. And then fluoride, fluoride is in most toothpaste. Fluoride is an antiseptic. That's the reason they put it in there. But it's also a neurotoxin, and fluoride destroys your thyroid function. So we have to eliminate fluoride, not just for its antiseptic effects on the oral microbiome, but to maintain normal thyroid function and to prevent the neurotoxicity of fluoride. And then the other thing is people with poor oral hygiene, people with periodontal disease, gingivitis. What's happened in those patients is the bad bacteria have outcompeted the good bacteria. And so now they've got complete oral dysbiosis. And it's not just eradicating all the bacteria, but it's creating the dysbiosis that we see. So what we're finding in kind of when we calculate the amount of people that get a benefit from nitrate, it may be 10 to 15% of the population because of the mouthwash use, the oral hygiene, the fluoride in the toothpaste. So only 10 to 15% of the people who take nitrate-based products, whether it's beetroot juice or eating a plant-based diet, are getting a nitric oxide benefit from it.
Right. So, is it a fair statement to say that sound nitric oxide levels in the blood are downstream of of good oral health?
I think that's fair because in order so we measure, nitric oxide is the bioactive molecule that we're all after because it's a gas and it dilates the blood vessels. So to get there from nitrate, this requires a 2-electron reduction to nitrite and then a 1-electron reduction to nitric oxide. But when nitric oxide is being produced, it's oxidized in the blood to nitrite and nitrate, and that's how our body recycles, and we get this really complete time course and time release from a good diet and supporting a healthy microbiome. So what we look at in the blood of plasma of patients or humans is what are your steady state nitrite concentrations? And this is dependent upon how well the blood vessels are producing nitric oxide, but also the conversion of nitrate from the diet or how much is recycled into nitric oxide and nitrite in the saliva. So all of those are dependent upon really not just endothelial function and the function of the enzyme, but also how much nitrate we're getting from the diet and the ability of the bacteria or the presence of the bacteria to metabolize that into nitrite.
Okay, that's helpful to know. So, another way I think more everyday people have been exposed to, I guess, this mechanism is if they're into sports performance, whether it be elite cycling, whether it be lifting weights, bodybuilding, all
Yeah.
this exercise stuff, right? Any pre-workout you have on the market usually has something called, well, I think you mentioned it, arginine and L-citrulline in it. The consensus view is, well, these vasodilators will help boost my body's natural levels of nitric oxide in the blood. Is that true?
No, it's not true. We once thought it was true maybe 30 years ago, but the innovations and the discoveries around new science really allow us to think differently than we did 20 or 30 years ago. And the reason for that is that the body's never deficient in these amino acids, right? These are semi-essential amino acids. You get it from the breakdown of protein, whether it's an animal protein or plant protein. But our body also makes it through the urea cycle. So the partial urea cycle is present in every cell. And through that partial urea cycle, we're always making citrulline and arginine through this cycle. So we're never deficient. Nitric oxide deficiency is never a deficiency in the amino acids arginine and citrulline. In fact, citrulline is a byproduct of nitric oxide production. So giving more doesn't produce more nitric oxide. We have to restore the function of the enzyme that converts that, and then the body has a way of regulating the flux of these amino acids at sufficient rates to produce optimal nitric oxide. So all of these pre-workouts or all these nitric oxide products that contain arginine, citrulline, save your money. They don't do anything. In fact, in some cases, in some patients, it actually can cause harm. And then the other problem I have with pre-workouts is most of them contain caffeine or other stimulants. So caffeine is a vasoconstrictor. So even if it's leading to some level of nitric oxide being produced, which is a vasodilator, the amount of caffeine in these pre-workouts will outcompete the vasodilatory effects of nitric oxide. So you basically eliminate the benefits of that. So the effects that people feel from pre-workouts is typically a caffeine-related effect because caffeine is a known ergogenic aid. There's less perceived exertion if you're taking caffeine. So all the effects of these so-called nitric oxide pre-workouts is probably just a caffeine issue.
I mean, I find it really interesting reading your materials in your book when you touch on the actual sort of mechanism behind how nitric oxide synthase actually boosts levels in the blood, and arginine being a precursor to that. But more precursor doesn't necessarily correlate with higher levels. It's
That's
around how you can stimulate the enzyme, if I'm correct, or my layman understanding of the work. So how can we go about actually boosting the efficiency of the enzyme?
Well, we understand what happens. The rate limiting step in nitric oxide production is when the body has a lot of oxidative stress and it oxidizes a cofactor called tetrahydrobiopterin, and we call this BH4. So the ratio of BH4 to BH2, which is the reduced versus oxidized version of that molecule, is what predicts NOS coupling and NOS function. So when we lose the ability, or when we oxidize that molecule, then you basically get, so the NOS enzyme is like two twins that come together, right? And then there's a flow of electrons through this enzyme that allows for the 5-electron oxidation of L-arginine into nitric oxide. So in order for this enzyme to be coupled, you have to have sufficient reduced amounts of BH4. So if we can preserve the reduced form and prevent its oxidation, then we can maintain NOS function and normal endothelial function and nitric oxide production. So what does that mean? We got to prevent oxidative stress, and nitric oxide completely suppresses oxidative stress, prevents NADPH oxidase, recouples the electron transport chain, prevents electron leakage and superoxide production, and we can recouple the NOS enzyme and prevent the superoxide being produced by the actual enzyme that's supposed to produce nitric oxide. So it's really self-healing. It's self-fixing, right? If we can restore the production of nitric oxide, then automatically there's less oxidative stress, and we can maintain the function of the enzyme. But just giving arginine or citrulline and a bunch of antioxidants isn't going to get it done. You have to understand the enzymology and the biochemistry of that reaction in order to do that. And I've been doing this for 25 years, and we know how to do that now.
Okay, great. I wanted to get into the sort of slight mechanisms first, and what the consensus view is and how it doesn't work, before we get into maybe what could work. Before we get there, I'd love to understand, if we don't sort adequate levels of nitric oxide out and we don't look to optimize it in our everyday life, what can go wrong?
Well, look, a lot of things go wrong because nitric oxide is a ubiquitous molecule, so it affects the blood flow and circulation of every organ, tissue, and cell in the body. So today we understand clinically, we see that if your body becomes deficient in nitric oxide and you become somewhat compromised, the first sign and symptom is sexual dysfunction, or what we call ED, erectile dysfunction. And this isn't just in men, it's in women. Right. So in order to get an erection in both men and women, you have to be able to dilate the blood vessels to increase blood flow and get engorgement. And that increase in blood flow is due to the production of nitric oxide. So if the blood vessels of the sex organs can't make nitric oxide, then you don't get vasodilation, you don't get engorgement, and that's erectile dysfunction, either in a penile erection or a clitoral erection. So without nitric oxide, there's no vasodilation, no increase in blood flow, no engorgement. That's the first sign and symptom, and we call that the canary in the coal mine because it tells us that it's a systemic disease. It's not just dysfunction in the vascular bed of the sex organs. You've got that same dysfunction in the coronary arteries, you get the same dysfunction in the cerebral arteries, and it's a systemic disease. So that's a first sign and symptom. And if you don't take steps to correct that, then what happens? Well, you develop high blood pressure. And then high blood pressure is the number one risk factor for the number one killer of men and women worldwide, which is cardiovascular disease. So even if you don't manage your blood pressure and you don't fix the nitric oxide problem, then you start to develop metabolic disease. Nitric oxide is required for insulin signaling and glucose uptake. So then you develop type 2 insulin-resistant diabetes. If not corrected, we're starting to see mild cognitive decline, vascular dementia, and Alzheimer's. And then somewhere in that mix, you start to develop exercise intolerance, because if you can't produce nitric oxide, then you can't dilate the blood vessels of the coronary arteries, so you get short of breath, you can't maintain an exercise regimen. And all of these are known risk factors for cardiovascular disease. So we have to take steps to, number one, recognize nitric oxide deficiency, and then employ these very simple strategies that can prevent the further loss of nitric oxide production, but more importantly, optimize the body's ability to produce it.
I mean, I'm pleased that you say that. In my research for this podcast, I learned that most ED or erectile dysfunction cases are actually nothing to do with testosterone. And they have adequate testosterone and adequate saturation of the androgen receptor. And actually the issue lies elsewhere, usually with the endothelial system, right?
No, that's right. There are a lot of things that are causing erectile dysfunction. I mean, testosterone activates and stimulates nitric oxide production, right? So if you're low in testosterone, you get less activation, less stimulation of the enzyme. But even if you do hormone replacement therapy and you give testosterone, if you don't fix the enzyme that makes nitric oxide, you can have optimal or high levels of testosterone, but if we don't fix the enzyme, you're never going to get vasodilation and activation of the enzyme, because the enzyme is dysfunctional. It's uncoupled. You can activate, stimulate till the cows come home, but you're never going to get nitric oxide out the other end. So we have to do two things. We have to fix the underlying enzyme in the lining of the blood vessels. And then if we optimize hormones on top of that, now we're going to get adequate stimulation and activation, and we're going to completely restore erectile function. But the majority of the cases we see, as you mentioned, aren't due to testosterone deficiency. It's due to endothelial dysfunction and the inability of those cells to produce nitric oxide.
Okay, so now I think it's a great time for the sort of $1 million question, right? So how do you boost nitric oxide levels in the blood?
Well, it's very simple. The science is complex, but the solution is very simple. And I tell people, you only have to do two things. Stop doing the things that disrupt it, and then start doing the things that promote it. And we've addressed a little bit of this. So what does that mean? If you're using mouthwash, you have to stop. Get rid of fluoride in your toothpaste. And if you're taking antacids, you have to stop. Antacids
what is an
antacids? Because
antacids?
we need
Okay,
stomach acid to produce nitric oxide. And there's a class of drugs out there called proton pump inhibitors, or PPIs. These are things like Prilosec, Prevacid, Nexium, Omeprazole, Pantoprazole. They're prescription drugs, but they're also over the counter. The Prilosec, Prevacid, OTC. So these drugs completely suppress nitric oxide production through the suppression of stomach acid. And there's data now showing that people who have been on these class of drugs called proton pump inhibitors for at least 3 years have 40% higher incidence of heart attack, stroke, and Alzheimer's. So it's completely shutting down nitric oxide production, leading to heart attack, stroke, and Alzheimer's. So we have to get people off antacids. So no mouthwash, no fluoride, no antacids. And now you've basically released the brake on nitric oxide production. Now your body's primed to do what it's designed to do. But we can help that. So moderate physical exercise, 20, 30 minutes of exercise a day, just enough to kind of increase your heart rate, deep breathing through the nasal sinuses, throw in some more green leafy vegetables to up your nitrate intake, and then 20, 30 minutes of sunlight a day. And those three things right there, those are cost savings. So what we're telling you here is going to save you money. You don't have to buy mouthwash, you can buy non-fluorinated toothpaste, and get off your antacids. And then just 20, 30 minutes of exercise out in the sun, 20, 30 minutes a day. Deep breathing, nasal breathing, and now your body can actually make nitric oxide. And then if all else fails, then we have product technology that does it for you. We provide a source of nitric oxide, and we fix the reason your body can't make it.
So I noticed the emphasis on nasal breathing there. Can you tell us more about that?
Yeah, so the same enzyme, the nitric oxide synthase enzyme that's found in the lining of the blood vessels, is also found in our airway epithelium. So the endothelial cells are inside the body. They line the blood vessels. The epithelial cells are found outside the body, in our airway sinuses and along the gastrointestinal tract. But these epithelial cells in the nasal sinuses actually can produce nitric oxide. They have an enzyme in there. So when we do deep breathing, there's mechanoreceptors on these epithelial cells, and when they're activated, it tells that cell to make nitric oxide. But again, the enzyme has to be functional. So when you have a functional NOS and you do nasal breathing, we're delivering nitric oxide gas to the pulmonary blood vessels, and we're delivering it down into the pulmonary bronchioles, the airways. And so the nitric oxide is going to dilate the bronchioles. So we're going to improve oxygen delivery and oxygen uptake. And it's going to dilate the pulmonary arteries to where you're going to get better oxygenation and match ventilation to perfusion. And you're going to get better oxygen delivery. So, but here's the problem. In people who have endothelial dysfunction, they also have epithelial dysfunction. So if the enzyme is uncoupled and dysfunctional in the endothelial cells, it's also uncoupled and dysfunctional in the epithelial cells. So in these patients, we see that even if they're doing nasal breathing, until we fix the enzyme that makes nitric oxide, they're not generating any nitric oxide through nasal breathing. And we can measure this through a nitric oxide analyzer, a gas phase analyzer. And we see that in either young kids that can't make nitric oxide, they don't produce any nitric oxide through nasal breathing, or when we fix the enzyme, now if they do nasal breathing, we can actually deliver the nitric oxide.
Okay, interesting. And regular exercise, does that boost the concentrations in the blood immediately, or is it like a progressive build over time, or both?
Well, it just depends. So there's two sets of people. There's well-trained athletes, and when you put them on an exercise treadmill, and then you draw blood, their ability to produce nitric oxide predicts their exercise capacity. So the athletes who can make more nitric oxide upon exercise, those are your well-trained athletes. Now, if we do that same experiment in older patients with known risk factors, whether they have diabetes, hypertension, smoking, high triglycerides, things like that, when we put them on an exercise treadmill, they fail to increase nitric oxide production because the enzyme isn't functional. And then that's diagnostic for endothelial dysfunction, ischemic heart disease, because if you can't make nitric oxide, you can't dilate the coronary arteries, then you start to see changes in electrical activity, and that's diagnostic for ischemic heart disease. So in well-trained people who have good endothelial function, when you start to exercise, that activates and stimulates nitric oxide production. And that's why exercise is medicine, because it's increasing nitric oxide production. But again, this is dependent upon the function of the enzyme. We have to fix the function of the enzyme in order for this to work.
So, and am I right in saying where the enzyme can go out of whack is through things like fluoride, through things like mouthwash? I mean,
Well, no,
if you have a problem with the enzyme.
Yeah, so that's a
Sorry, go on.
separate pathway, right? So the mouthwash and the fluoride are disrupting the oral microbiome. So that pathway is a compensatory, kind of redundant, independent pathway of the NOS enzyme. And there's enormous redundancy in the human body, right? So there's more than one ways to make this molecule. Nitric oxide being such an essential molecule, it didn't make sense to me as a biochemist and physiologist that there was only one way to make it. And this one way through this enzyme is a 5-electron multi-step oxidation reaction that's energetically and kinetically unfavorable. I mean, it didn't make sense that so there has to be a backup. And this backup pathway is from the diet and the oral microbiome. So here's what happened. The enzyme becomes uncoupled and dysfunctional just by known risk factors: sedentary lifestyle, oxidative stress, high carbohydrate meals where you get hyperglycemia, and then the sugar sticks to the enzyme and it no longer makes nitric oxide. Similar to hemoglobin A1C, it's a glycation event. That same sugar glycates the NOS enzyme and makes it dysfunctional. So people get into trouble. So you can get away with endothelial dysfunction if you eat a good diet, have the right oral bacteria, and have stomach acid production. So it can compensate for a loss of function of the enzyme. But when you have endothelial dysfunction and you're not feeding this dietary pathway, either you're not getting enough nitrate from your diet or using mouthwash, fluoride, or taking an acid, then your body's completely devoid of nitric oxide production. And that is when you see the slippery slope of rapid onset of cardiovascular disease, metabolic disease, and everything we've talked about.
Okay, so it's almost like because there's more than one mechanism, you want to try and optimize as many mechanisms as you can.
For sure.
Okay. Am I right? At what rate does nitric oxide levels decline in the human body?
Everybody's different, but there's studies out there where you're just looking at general population. So kind of an average pool of people walking around. And the data reveal that on average, we lose about 10 to 12% of our nitric oxide production every decade. And this can start in the late teens, early 20s. And then 10 to 12% stepwise decline in production. So by the time we're 40 or 50 years old, on average, the normal person has about 50% of the nitric oxide they had when they were in their late teens, early 20s. But today we understand that you can accelerate that or decelerate. So we're seeing now 20, 25-year-old kids with the vascular age and the endothelial function of a 60 or 70-year-old. 10 to 12% of their nitric oxide full capacity. And then, I'm always the kind of the N=1 guinea pig. I turned 50 in November, but I've got the vascular age of a 30-year-old, right? So I've been able to reverse that and shift that curve to the left or to the right and basically preserve my nitric oxide. So although we see this age-related decline in nitric oxide production in most patients, we now know how to accelerate it, which we hope we don't do, but more importantly, decelerate it and maintain optimal nitric oxide levels when we're 50, 60, 70-year-old, as we did when we were 20 or 30. And that's certainly achievable through the science and the product innovation that we've discovered over the past 10 years.
Okay, so I'd love to get into the product innovation side of the equation. Just a couple more things on this because I just want to, before we hone it out. When it comes to the different mechanisms of essentially nitric oxide optimization. You mentioned the sort of the I guess the oral pathway, and you mentioned the enzyme
Yep.
pathway. I'm conscious of a study out of Glasgow where it says the underlying of the endothelial system is the mitochondrial system. If I'm correct me if I'm wrong. How does mitochondria function play a role in sound endothelial function and sound nitric oxide levels?
Well, mitochondria are the energy producing organelles of the cell. They're found in every cell type except for red blood cells. And red blood cells are actually the oxygen carrying capacity, and that's their main job. But the mitochondria are what provide every cell in the body the energy to do its job, and the energy currency is ATP. And these mitochondria take oxygen and basically reduce it down to water and then produce adenosine triphosphate as a currency of the cell. So there's a complex, what's called an electron transport chain, and there has to maintain an electrical potential across that intermembrane space. And then you've got to have this flow of electrons to reduce oxygen into water and allow for ATP production. So nitric oxide is what controls electron flow through the electron transport chain. It prevents electron leakage. So what happens when you make sufficient nitric oxide, you basically can more efficiently reduce oxygen to ATP or ATP production with less oxygen, right? So you're basically miles per gallon of 40 miles per gallon. Where if you can't make nitric oxide, then you've reduced the efficiency of that, say from 40 to 6 miles per gallon. So you've lost the efficiency of energy utilization. And then so those are the kind of the acute effects, and then the adaptive effects of nitric oxide basically induces mitochondrial biogenesis. So when our body's making sufficient nitric oxide, that induces a pathway called PGC1 alpha. It's activated by sirtuins, intermittent fasting, caloric restriction, and then that allows for that cell to have more mitochondria. So what that means at the end of the day is in a person who makes sufficient nitric oxide, you've got more mitochondria per cell, generating more energy more efficiently with less oxygen. And now you become
Okay,
a well-oiled machine. But all
okay,
of
so it's
this is
not
dependent
necessarily
upon the cell's ability to produce nitric oxide. If you can't make
right.
nitric
Okay,
oxide, you have mitochondrial dysfunction, and you have lower numbers of mitochondria per cell, and those are hallmarks of every single chronic disease.
okay, that's really interesting to know. So, how do we test our levels of nitric oxide?
Yeah, it's a good question. Um, there's really no labs like we can test your cholesterol or lipids or vitamin D or magnesium levels because nitric oxide is a gas, and once it's produced, it's gone in less than a second. So there's really no blood labs that can determine our nitric oxide levels. About 15 years ago, I developed a salivary test strip where we could apply some saliva to the end of this test strip, and it would give us a proxy for what we call total nitric oxide availability. But it's a chemical test, and there's some false positives. And so I've gotten away from using the test strips because, people with active oral infections will have a false positive. They'll show optimal or ideal when systemically they're completely devoid of nitric oxide. So what we have to do is rely on symptoms. And if you have ED, then you're not making nitric oxide. If your blood pressure is elevated, you're low in nitric oxide. If you've got insulin resistance, diabetes, or metabolic disease, then your body's not making nitric oxide. If you can't go out and walk briskly for 10, 15, 20 minutes without getting out of breath, then you've got a nitric oxide problem. So we rely on symptoms and clinical presentations as the driver for nitric oxide based either therapies or product innovations.
Okay, I wonder if there's a correlation between VO2 max and nitric oxide levels. I mean, it's hard because you can't test them, right? But
No, you can't look. There's a very good correlation between nitric oxide. Adequate nitric oxide production actually improves VO2 max, right? Because you're looking at the efficiency of oxygen utilization. And there's different endpoints. You can look at ATP ADP ratios. You can look at VO2 max measures, and when you increase your workload, how efficient are you utilizing oxygen? So all that's dependent upon nitric oxide.
okay, wow, interesting. I mean, coming at this before, I would have, hazarded a guess of high VO2 max boost nitric oxide levels, but actually, it seems like it's the other way around, right? If I'm hearing you correctly. I'd like you mentioned sort of technological innovations and where you're at now with your work. I'd love to understand sort of what the latest and greatest is in this field.
Well, what we've done is a little bit different than anybody else in the industry or in the world for that matter. So We only developed product technology once we understood the enzymology and the biochemistry of how the human body makes nitric oxide, what goes wrong in people that can't make it, and then and only then could we develop technology that provided a source of nitric oxide and then fix the reason your body can't make it. So we make products that actually produce nitric oxide gas. And really, this goes back to 2007, because in 2007, my group published a paper showing for the first time that nitric oxide is a hormone. So similar to hormone replacement therapy in men and women in giving testosterone or estrogen, all we have to do is restore the production of nitric oxide, right? So if you're low in testosterone, your doctor doesn't give you precursors and hopes your body can convert it into testosterone, right? That's the reason you're deficient. So it makes no sense giving precursors in the form of nitrate or arginine or citrulline to produce nitric oxide, because the reason you're deficient is you can't utilize those substrates to make it. So what do? We give intramuscular injections of testosterone. What do? We deliver nitric oxide gas in the oral cavity or in the lumen of the stomach. And we do this through an orally disintegrating tablet. You put this lozenge in your mouth. It takes 5 to 6 minutes to completely dissolve. But during that 5 to 6 minutes, it's constantly releasing nitric oxide gas. It's vasoactive. We can see dilation of the carotids within about 15 seconds. If you have high blood pressure, we can see a normalization of blood pressure within 15 or 20 minutes. So what we're delivering is bioactive nitric oxide gas. So if your body can't make nitric oxide, we do it for you. But that's only part of the problem. So we don't want to give your body something like testosterone. If you take testosterone, it shuts down endogenous production of testosterone. So now you become dependent upon that. What we wanted to do was completely different. We wanted to, one, give you a rescue dose of nitric oxide. But now that we understood the enzymology and the biochemistry, we can put technology in there that prevents the oxidation of BH4. We can recouple the NOS enzyme. Now we're improving the body's ability to make nitric oxide on its own in the lining of the blood vessels and in the nasal sinuses. And we're restoring the oral microbiome. Because this lozenge sits on the tongue, you can move it around. It kills the pathogenic bacteria, and it improves the diversity of the microbiome. So now we're waking up and we're basically improving the numbers of these nitrate-reducing bacteria. So now we've increased the diversity of the microbiome, we've restored endothelial function, and we've improved the body's ability to make nitric oxide on its own.
Wow. Is it on the market?
Yeah, we've had these products on the market for more than a decade. We make a lozenge, we make a fermented beet powder. The beets, you guys in the UK led this whole beet storm back in the 2012 Olympic Games, and then there was a flooding of market with beetroot products, right? But unfortunately, I've tested these. 95% of the beetroot products on the market have no nitric oxide activity whatsoever. So beets don't necessarily mean there's nitric oxide. And the mechanism of that is the nitrate. So if you're taking beets with nitrate, you don't have the right bacteria, then all it's going to do is turn your pee and your poop pink and cause a lot of anxiety. So what we did was we go, okay, we understand this, so we can take our beets and we ferment our beets, so we optimize the nitric oxide activity. We take out the beet pulp, the beet color, the oxalates. So now we have a white beet powder that doesn't look or taste like beets, free of oxalates. And then we add electrolytes and we add mitochondrial ATP. And we call that product NO Beets, and it's a fantastic pre-workout or energy product because it's providing nitric oxide, it's providing electrolytes for cellular hydration, and it's providing mitochondrial ATP.
Okay, nice. We'll have to check that out. I mean, I'd love to be a guinea pig.
Yeah.
Let me add it. I'm my sort of my story into all of this was I used to play lots of rugby and lots of sort of competitive athletics, and before any event or any rugby tournament or whatever it was, I used to eat as much beetroot as I can, probably about 3 or 4 days before. I also used to take cordyceps, purely because there was one article about the Chinese Olympic team taking it back in the 90s, and I thought, great, this mushroom is going to help me with all my endurance gains. And I know it does some interesting things to a similar mechanism. Actually, I'd love to get your thoughts on that. Actually, how does cordyceps play into this?
Well, look, there's enormous data now on the therapeutic benefits of cordyceps. And so this goes back to, natural product chemistry, things that are in nature that provide benefit to the human. And there's this whole field of nutritional epidemiology of what's responsible for the cardioprotective or cytoprotective benefits of certain diets or certain foods. And mushrooms and cordyceps is certainly one of those. And there's a number of different mechanisms that they're hitting on. They're upregulating kind of these antioxidant defense response elements. They're downregulating some inflammatory things, but the data are pretty impressive on cordyceps. It's kind of outside my field of study, but I think what we're doing, if we can restore the production of nitric oxide, then part of the mechanism of things like cordyceps and even infrared sauna and a lot of these other biohacking things, they're actually stimulating and activating nitric oxide production. So they may be upstream from nitric oxide, right? And then some are maybe even downstream. But I think all of these things have benefits, and we have to understand. What I like to do is take important clinical observations. So if you take something and you notice a benefit, then let's work backwards and figure out what's the mechanism of that. Then we can make it better. And that's what we've done with nitric oxide. We take important clinical observations, work backwards, figure out mechanism, and now we can actually optimize that. And that's what we've done through our product technology.
It's often the case, isn't it? You get the innovation and no one knows what to do with it, right? Penicillin is an example.
Well, yeah, and that's why basic science never makes it to clinical practice, right? Because every basic scientist has their favorite protein or enzyme and they want to make a clinical application to it. But it's like fitting a square peg into a round hole. It doesn't fit, right? So if you start with an important clinical observation, something that's known to have clinical benefit or improving human physiology, now you can work backwards and figure out the mechanism and then focus on that. Focus on what works. Don't make a discovery and then try to make it work clinically. Take what works clinically, work backwards. Then once you understand it, you can optimize it.
On this is a perfect segue. On what works clinically and is very much relevant for this topic of conversation is PDE5 inhibitors.
Yes.
And for those who don't know, this would be your sort of generic Viagra, other sort of brand names, things like this.
Yep.
And the reason I bring it up is, extremes, good or bad, educate the best. And this pathway that these pills activate can tell us a lot about how this whole mechanism works. And I'd love to get your thoughts on PDE5 inhibitors. And then I'd love to tangent into Alzheimer's because I'm relevant to your technology you just mentioned as well. So I'd love to get your thoughts.
Well, the PDE5 inhibitors have been on the market since 1998. So we're 26 years of these drugs being on the market. And for those of you who don't know the history, these drugs were first developed for conditions like ischemic heart disease and pulmonary hypertension. Because the mechanism of these drugs is they inhibit an enzyme called phosphodiesterase. They're called phosphodiesterase isoform 5 inhibitors, or PD5 inhibitors. So this enzyme breaks down a second messenger called cyclic GMP. And this is going to get somewhat complicated, but I want to make sure that this is clear. So when nitric oxide is produced, it activates a second messenger and leads to an increase in cyclic GMP. And then cyclic GMP is what's responsible for mobilization of calcium, smooth muscle relaxation, and vasodilation. So if you prevent the breakdown of cyclic GMP, you can potentiate the vasodilatory effects of nitric oxide. Right? So nitric oxide turns this switch on, and then these drugs keep it on. And you've all heard the commercials. If you have a 4-hour erection, go to the ER. It causes an unsafe drop in blood pressure because once you activate this pathway, it dilates, then it stays dilated. So if you dilate all the systemic blood vessels, then you're going to get loss of perfusion pressure. You're going to get, lightheadedness, syncope, and you may even pass out. Or you're going to get a priapism because the dilation of the arteries of the corpus cavernosum are going to maintain open, prevent outflow, and then you're going to get necrosis. So it may seem like a joke, but this is a clinically severe issue. But 26 years on the market with these drugs, only 50% of the men that are prescribed Viagra, Cialis, or Levitra, these PD5 inhibitors, respond with better erections. So that means 50% of the people that are given these drugs don't respond. There's no therapeutic benefit. And now that we understood the mechanism of action of these drugs, the non-responders are non-responders because their body's not making enough nitric oxide to activate cyclic GMP. So there's no cyclic GMP to break down. So there's no substrate or no inhibition on the breakdown of that. So now what we find, and we've demonstrated this clinically, if we give our lozenge increased nitric oxide production, now non-responders to Viagra, Cialis, or Levitra can now respond with better erections and better symptoms of or urinary symptoms of BPH, which is benign prostate hypertrophy, then they get better. Now we can actually make these drugs work. And I think more importantly, you can titrate down the dose of these drugs, making them safer and more effective. So the therapeutic benefits of these drugs, PD5 inhibitors, are dependent upon the cell's ability to produce nitric oxide. So again, erectile dysfunction is a symptom of nitric oxide deficiency. It's not a symptom of overactive phosphodiesterase enzyme.
I think it's a really important point as well, because if someone was to take a snapshot of our conversation at the start and get bought into the benefits of having sound nitric oxide levels, and then go about their day and not listen to the rest of the episode, they might think, okay, cool, well, that's surely an easy fix just to get on these PDE5 inhibitors. But that doesn't actually boost your body's level of nitric oxide.
No, they're right.
And an interesting one as well.
Yeah, it potentiates the effects of nitric oxide. But if your body can't produce nitric oxide, these drugs aren't going to provide any clinical benefit. But the ones that do, and these are data that came out, I think at the end of COVID, and when you follow these kind of prospective studies, you're finding, and you've probably seen the report out probably a year ago, that people who had been on PD5 inhibitors for a number of years, I can't remember maybe 3 to 5 years, had about a 40% reduction in the onset of Alzheimer's. So these are very important clinical observations. And now that we understand mechanism, we can explain the important clinical observations. So they're improving blood flow, they're improving circulation, they're potentiating nitric oxide. So now we know that Alzheimer's is a vascular problem. It's diabetes type 3, and it's characterized by decreased blood flow or focal ischemia. So when we give nitric oxide, we improve cerebral blood flow, we potentiate insulin signaling, we enhance glucose uptake, and basically we address all aspects of Alzheimer's disease. And that's what allowed us to get our drugs into an Alzheimer's study, because we're pretty confident, not pretty confident, we're extremely confident that nitric oxide will get to the root cause of Alzheimer's and eliminate this horrible disease.
Well, I'm pleased you brought it up, and I've literally got the study right here. So PDE5 inhibitors in men with erectile dysfunction and the risk of Alzheimer's disease from the Journal of Neurology. And the conclusion, as you said, is there's something like I think it's an 18% reduction
maybe
in Alzheimer's risk. But then it's dose dependent. So the people who had more of this stuff had a better response. But this Alzheimer's as a vascular disease has been coming up for a while. I mean, I remember first reading about it in a book called How Not to Die, Dr. Michael Grieber, I think. Fantastic book, and they mentioned it could be a vascular disease. And then you see Uri Laukonen's work out of Finland showing a 66% reduction in Alzheimer's and dementia off a sauna for 4 times a week, 20 minutes. And it's like, okay, well, what's the mechanism behind this? And it's like, well, the sauna is a vasodilator, right? And then you read the Alzheimer's study with PDE5 inhibitors. It's like, okay, well, vasodilation, better nitric oxide levels, or things in your blood. So I get intuitively as a layman, the mechanism behind this can make sense. So moving forward, what are you doing to explore this pathway further with your work?
Well, look, everything's about blood flow, and nitric oxide is what regulates and controls blood flow to every organ, tissue, and cell in the body. So although we've had consumer products on the market for a number of years, I've got a drug company called Bryan Therapeutics, and we're actually moving this technology into clinical trials. So we want to get through the FDA for specific indications. So our nitric oxide drug, our lead drug, we've got it in clinical trials for ischemic heart disease because it's very effective at dilating the coronary arteries and prolonging exercise-induced angina. And then our Alzheimer's drug. So the hallmarks of Alzheimer's, it starts with vascular dementia, right? So, and we can characterize this through SPECT scans of the brain or functional MRI. But every vascular dementia Alzheimer's patients shows a loss of regulation of blood flow. So there's reduced blood flow to the prefrontal cortex. So number one, it's a vascular problem. And then number two, you've probably heard Alzheimer's called diabetes type 3, right? The brain likes glucose. It uses sugar as a primary energy substrate. But you develop insulin resistance in Alzheimer's. So then you basically lose glucose uptake, you lose the insulin signaling in the brain and the neurons, and you develop metabolic disease. So the whole aspect of Alzheimer's is if you can't get the good stuff in and take out the metabolic waste products because of poor circulation, then you start to get misfolding of proteins. And what is that? That's beta amyloid plaque and it's tau tangles. And so all these drug companies out there developing drugs targeting the amyloid plaque and the tau tangles have failed. And to me, it's obvious. They're targeting the consequence of disease. They're not targeting the cause of disease. But that makes it a little bit harder for us to do what we want to do, because people think that Alzheimer's is this incurable thing, because the data have shown you can reduce plaque by these monoclonal antibodies, but it has no regard to clinical outcomes or improvement in the clinical symptoms. So it's an epiphenomenon. It's a consequence of disease. What we're trying to do is completely different. Restore normal physiology, restore blood flow to the brain, potentiate insulin signaling, glucose uptake, get the good stuff in, take out the stuff, prevent protein misfolding, and the body heals itself. I mean, it's really that simple. And that's what we're after, that no one else has been able to do or even pursue. And so, we think in the next couple of years, we'll have our Alzheimer's drug through clinical trials and hopefully a safe and very effective drug on the market, and we'll eliminate this horrible disease.
Wonderful. Well, obviously wish you best of luck among with many other people. So, Dr. Bryan, what do you do on a daily basis to optimize everything we've been speaking about?
Well, Ben, it's hard work. As you know, like, it's hard work staying healthy, but it's harder work getting healthy if you're sick. So we all got to work hard. I would rather work hard being proactive instead of reactive. But I practice the principles that I know that work. Not only work me and I see the results, but have clinical validation, and that the mechanism is very well defined. So, number one, I do a 16 to 18-hour fast every day. I eat my last meal at 5:30 or 6 in the evening. I don't eat breakfast. I eat lunch the next day. And then, I eat a lot of high protein meal, some vegetables, very little carbs. So not a straight carnivore diet, but probably more in line with a ketogenic diet. I take a lot of supplements because the food we eat, unfortunately, is depleted in most nutrients. So I wake up every morning, I take an algae product, chlorella and spirulina, which contain a lot of micronutrients and really replete with a lot of vitamins and minerals. I take my nitric oxide daily. When I'm at home, I have a hyperbaric oxygen chamber. I sit in an infrared sauna. That's how I start my day. I get up at 5:30 or 6. I spend 30 minutes in my infrared sauna at 170 degrees. Put an ozone generator in there, so I'm getting fully oxygenated. It helps me detox. And during that 30 minutes, I start out my day with my prayers, my meditation, and just this feeling of gratitude. And then, that starts my day. And then, I go and, I do podcasts. I travel every week giving lectures. And, I'm out, I've kind of retired and resigned from full-time academia. But now my mission is to go out and educate and inform on nitric oxide. But yeah, and then I work out usually every day when I'm not, even when I travel, I still try to go to the gym. Usually 15, 20 minutes of cardio and then 30, 45 minutes of resistant training. Because we have to eat well, balanced diet in moderation. We have to move, we have to exercise. And then we got to give our body the essential minerals and vitamins it needs so it can do its job. Then I try to avoid exposure to chemical toxicants, right? And that's hard to do. I don't drink tap water. Tap water is horrible. And then, I try to, I go to the dentist once a year, make sure I don't have any dental infections. Those are really bad for you. And then, I grow my own food. I raise my own beef, no hormones, no antibiotics. I grow my own vegetables, no herbicides, pesticides, but I grow these vegetables in nutrient-rich soil. So when I'm at home, that's very easy. When you travel, it's very difficult to get good, clean food, but we try to do the best we can.
Absolutely. And the more suddenly the harder it gets, because it's hard to be, optimal and keep your health when you're in, Manila airport at 4 o'clock in the morning or whatever it is,
Yeah.
right? But
and then, it's dealing with stress. Everybody has stress. What we're doing is particularly stressful because we become a target from a lot of people. And, people come after you when you're doing things that are going to disrupt and change the world. So I wear that as a badge of honor. So it used to bother me, but now it's how we deal with stress that really predicts or, disease prevention, because stress is certainly a killer. We all have stress. We just have to deal with it in a manner that doesn't kill us.
Completely agree. We have someone coming on the podcast who's an expert in placebos, and the placebo in the mind is something I really want to speak to her about. You
For
mentioned
sure.
just in
No,
your
there
daily
is.
routine. You mentioned gone.
No, I was gonna say, look, there is a real placebo effect, and that just shows you how powerful the mind is. If you believe something, you can manifest that, and I think that's really successful people manifest what they where they want to be, what they want to become, and it happens. Those that can't manifest, or if they think they're taking something that's going to provide benefit, that placebo effect is real, and that's why in clinical trials through the FDA, we have to do a placebo controlled clinical trial because the mind is a very powerful organ.
Very, 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 very. I mean, placebos work even if you know they're a placebo, right?
That's
So if you
right.
take a sugar pill and this is going to make me feel X, Y, and Z, like it literally does work in a very bizarre way. And then another one on this was just reading it the other day is the placebo drug or the placebo effect is the most studied control in history, right?
Yeah.
Because for everything you're testing, there's got to be the placebo there as well. You mentioned you take your nitric oxide. And are you talking about one of your products? What are you talking about there?
Yeah, so we make a nitric oxide lozenge. It's called N101 nitric oxide lozenge. So I take that every day. That's usually how I start my morning to get the blood flow going, get the circulation going. Um, and then, so yeah, usually one of those once in the morning, sometimes one in the evening, or typically I'll take in the evening the fermented beet powder before my workout. 5 minutes before I go to the gym, I'll take this beet powder, put it in 2 to 3 ounces of water, mix it up, and then take it as a shot. And that's producing nitric oxide as soon as it hits solution. So those products are at n101.com. That's the letter N, the number one, the letter O, the number one.com. And we also make a topical nitric oxide for skincare and beauty, which is an incredible product for fine lines and wrinkles and for aging skin. Because again, the skin is an organ just like the sex organs or the heart. If your body can't make nitric oxide, that organ fails and you develop fine lines and wrinkles, you lose hydration, you lose collagen, you develop age spots. So when we apply nitric oxide topically, we improve blood flow, we mobilize stem cells, we repair and replace dysfunctional cells, we improve collagen deposition and tone, texture, and clarity of the skin improves.
Wow, amazing. Well, Dr. Bryan, that was awesome. Really, really enjoyed that. I could speak to you for you know a long while, and
Yeah.
hopefully we do this in
Well, thanks,
person one
Ben.
day. That'd be really fun. Where can we find more about you? Where can we follow with your work?
I send people primarily to my educational website. It's drnathansbryan.com. I do a monthly blog. I've got some videos on there that'll educate and inform you on the role of nitric oxide. You can find me on YouTube. I have my own YouTube channel, Dr. Nathan S. Bryan, nitric oxide. Instagram, Dr. Nathan S. Bryan. I'm on Twitter at Dr. Nitric, LinkedIn. Uh, I'm out there. I'm searchable on most search engines. You can, if you're interested in our peer-reviewed publications, go to PubMed. We've got over 100 peer-reviewed papers on nitric oxide in the published literature. Uh, and then, as you alluded to, I've got a book coming out here in a couple of months called The Secret of Nitric Oxide, Bringing Nitric Oxide to Life. And the purpose of the book is really to tell the story of nitric oxide from its discovery to our clinical translation of this molecule and to really educate and inform on nitric oxide, but also to kind of illustrate my personal journey through this and really to help hopefully motivate and inspire people that, against all odds, you have to keep moving forward. And, we've encountered a lot of hurdles and resistance and opposition to what we're doing, but, what we're doing are fundamental truths. And, it'll be self evident, but hopefully it's inspirational and encouraging people that no matter what you're going through, keep your head down, believe in your dreams, and keep moving forward.
Well, I think that's a lovely place to end. Dr. Bryan, thank you so much for going on.
Thank you, Ben. It's been a great pleasure.